How did your class go?
First night went really well. We have 29 students.
Good. That's great.
Everything went well. We'll be back at it tonight.
Another long day for you.
It's all right.
Okay.
I can do that. Oh, first of all, I'm going to turn this. You still low on John?
Yep, for at least another month. Okay.
You can fix it back now.
Yeah, that's great, really.
Okay. Let's get going.
Okay with that.
This is Nancy Dixon, second best nurse in the world.
Now I'm first nurse, right?
Well, well, yeah, okay, yeah. Best nurse in the world. I got to clarify all that. She was best nurse in the world for a long time until my oldest daughter became a nurse. And that kind of bumped her down to second best nurse in the world. But now my oldest daughter became a nurse practitioner, so bumped Nancy back up to...
Congratulations.
Yeah. We have worked together for 35, 36 years, yeah. Yeah. I'll let her tell you about her experience and all the stuff that she's done. She's awesome. So, yeah. Anyway, Nancy Dixon, she's going to teach you everything you ever wanted to know about shock.
Cool.
Okay?
And don't be afraid to ask.
Right. Okay. They're all yours.
Okay.
Thanks, Nancy.
Well, like John said, I'm Nancy Dixon. I work as a nurse in the emergency room at Intermountain Medical Center. I've been with IHC in the ER, well, coronary ICU for about 3.5 years, but the ER most of the time for about 24 years. So, been doing this for a while. But what makes me, I think, specifically qualified to teach EMTs and paramedics is I was a deputy sheriff paramedic for Davis County for 10 years. So, and my claim to fame is I was actually Utah's first female paramedic. So, which was really interesting. So, I went through paramedic school, I graduated from paramedic school in 1983. And I remember Evelyn Draper, who was the director of the paramedic program at the time, which was the only paramedic program at the time, said, Nance, how you doing this program is going to determine if any other women get in. I'm like, okay. I was 18 at the time. So I was also the youngest person to go through paramedic school. So it was a challenge, but it was good. Had some interesting experiences. So deputy sheriff paramedic for Davis County, and then I worked for AirMed for about 3.5 years as a flight paramedic. It was fun. Sorry, the competition, because John was flight, I was AirMed.
She worked for the B team.
I worked for the B team. I can take it. Anyway, so I do have a little bit of background, and I know sometimes it's hard having lectures done by nurses and for people who have never been pre-hospital, because it's a different ballgame, right? It's a different ballgame when you're milling in antifreeze and you're, you know, I remember starting a line on a patient one time that I could only find an arm. It had a pulse. We were waiting for extrication, and we were in the middle of South Weber with, you know, minus 30-degree chill factors in the middle of winter, and having my tubing freeze before I could actually get my line, you know, I got my line started, went to go hook up the line, and the tubing was frozen. So, you know, we just don't have to deal with that in the hospital. So, but I do understand. I do know what it's like. I've done a lot of teaching. I taught EMT school and paramedic school for Weber State University for many, many years, and have taught here for Unified Fire. I think for about 18, I usually teach their paramedic program. This is my first time teaching an advanced EMT class for Unified.
This is our
So-
first time going through.
This is your first time going through. Well, and actually, I understand the person who was originally supposed to teach this lecture could not. So bear with me if I have to refer to notes to make sure that I keep on track. I actually was just able to access your book for the first time last night. So anyway,
Wrong, so.
so which most of you probably accessed your book for the first time last night. So we'll be on the same page here. But anyway, but you know what, like I said, so bear with me if I have to look at my notes to make sure that I'm not missing anything for you guys, because I want to make sure you get the information that you need. So we are going to talk about shock today. And, you know, some of the main objectives as I go through shock with you is I just want to make sure that you guys know what shock is, the different causes of shock, the different, and basically how to treat shock, recognize which kind of shock you're dealing with, and obviously be able to treat them and know your priorities in transporting and treating the shock victim. So as we look at shock and resuscitation, again, here's basically our goal. This is what we want to be able to accomplish in treating shock. That apply your fundamental knowledge, okay, so that you can understand and know what shock is and the resuscitation, etc. So we're going to talk about the pathophysiology behind shock, okay? What's actually happening when someone is experiencing shock symptoms, okay? So we're going to apply the comprehensive knowledge of the pathophysiology of respiration perfusion to the patient assessment and management, okay? So that you can understand the pathophysiology, and then because you understand the pathophysiology behind shock, you'll be able to recognize when it's occurring. It's like, oh, I get it. I know why this is going on. I see exactly now what's happening. You know, the main goal of being a pre-hospital provider is to see the train coming before it hits you, right? You want to be able to recognize the problems and get on top of it before that train actually really hits. So, what is shock? Okay, so think about in your mind when you hear someone is in shock, and you know we hear this term all the time, right? You know, and it's kind of used loosely, I think. Oh, this person is in shock. You know, and you're looking at them and going, no, I don't think so. Okay, So what is shock? Tell me your definition of shock. I mean, you can all see what this definition is, but tell me what your definition of shock is.
Something's impacting perfusion.
Right, you've got crappy perfusion going on. Okay, shock, the actual definition is a collapse of the cardiovascular system. What's all involved in the cardiovascular system? Heart,
Veins.
And blood.
right? Heart and all the vessels that go with it, from arteries to arterioles to venules to veins to capillaries to the respiratory system. Okay, the respiratory system is part of the cardiovascular system. Okay, so it's heart and lungs. So when you're talking about a collapse of the cardiovascular system, you're talking about a problem with one of those components of that system, heart and lungs. Something's not going right, okay? And so therefore because of that problem with that system, that person is going into shock. So it's also known as hypoperfusion, which can be related to what? Either the pump's not working, the blood's not there, or the respiratory system isn't functioning like it's supposed to. Okay, so you have hypoperfusion. Okay, the body attempts to maintain homeostasis in the early stages of shock. So we're going to talk about the early signs and symptoms of shock. So again, you can kind of see the light of that train coming before you're slammed and hit by it. Okay, so you can recognize the early symptoms so that you can intervene to prevent the late symptoms of shock. Okay, so the body attempts to maintain homeostasis, and I mean we were brilliantly designed. We have got backup system after backup system after backup system to keep our bodies going. Okay, and we're going to talk about some of those backup systems that occur. And as this cardiovascular system continues, blood circulation will slow and eventually cease, generally known as a bad thing. Okay, when blood circulation ceases, that's generally bad. Okay. So shock can occur because of medical or traumatic events. Okay, so it's not just trauma, it is not just bleeding that causes shock. And that's what I really want to drive home, is that shock can be caused by all sorts of different things, okay, that can affect those systems. So, I mean, can you think of a heart attack causing shock? I mean, is that generally something that comes right to your mind when you think of, oh, this person is in shock, they must have had a heart attack? That's not the first thing that comes to your mind, is it? When you think, oh, this person is in shock, what's the first thing that comes to your mind? Trauma, right? They've had trauma happen. They've got bleeding, they're bleeding out, so therefore they're going in shock. But no, again, shock can be caused by all sorts of things that affect these different systems. So, shock can be caused by a heart attack. What about severe allergic reaction? Okay, maybe that one has a little bit better association with shock. What is that shock called? Anaphylactic shock, right? So yes, anaphylaxis can cause shock symptoms. Automobile crash, obviously here you're dealing with the trauma, okay? But an automobile crash, the trauma can also cause what other type of shock besides hemorrhagic? Neurogenic, if they've got a cervical spine injury. Okay, so then you could be dealing with a neurogenic shock. Can you have neurogenic shock and hemorrhagic shock at the same time? Yes, you can, okay? And so what you'll find is that you'll sometimes have these mega code of things going on where you've got all sorts of stuff happening and you've got to sit and sort it all out, and that's part of your job, is to sort it out and figure out what's going on with this patient, okay? Gunshot wound, okay, that's your trauma, also involved with shock. So you've got to be constantly alert to the signs and the symptoms of shock. And again, your main goal, and I teach this when I teach paramedic school, the main goal is that you always want, if that person's going to die, you want them to die on the next person, right? So as EMTs, if that person's going to die, you want them to die on the paramedics, and the paramedics want them to die in the ER, and the ER wants them to die in the ICU or the OR. Not that you want this person to die, but if that's what's going to happen, the goal is let's just get them stabilized and let's get them on to the next place, okay? Because if that's what's going to happen, you want it to do it on the next person, okay? You want to see that happening. So you've got to be constantly in alert and vigil and watching for these signs and symptoms of shock. And that's going to be one of the main objectives of getting through this lecture today. So as we talk about perfusion, okay, let's talk about the physiology of perfusion, okay? Perfusion is the circulation of blood within an organ or tissue in adequate amounts, okay? And when we're talking about adequate amounts, what are we talking about? What amounts of what? The right amount of blood, okay? What else?
Oxygen.
The right amount of oxygen, okay? We even want the right amount of byproducts, okay? You don't want too much CO2. You don't want too less CO2, okay? Too little CO2 can actually cause vasoconstriction. Too much CO2 can cause vasodilation. So there's all sorts of things involved here that you want to keep in balance. So you want it in adequate amounts. So the body is perfused. So you have your systemic circulation and you have your pulmonary circulation in the lungs. So all of those things need to be functioning correctly, okay? And it's important to understand this concept as we talk about the different types of shock that we're going to be talking about later on in the lecture. Systemic circulation in the body, so all of the vessels need to be working correctly. They all need to be intact, okay? They can't be leaking out. And the circulation in the lungs, this needs to be intact. It needs to be non-obstructed. It needs to be, not filled with fluid. It needs to be working correctly, and there needs to be adequate amount of oxygen there. Cardiac output, okay? When you think about cardiac output, what is cardiac output? Give me the definition of cardiac output.
Volume and rate.
Sorry?
Stroke volume and rate.
Stroke volume and rate. It is the amount of blood that your heart is able to pump in a minute. Okay? That's your cardiac output. So it is based on myocardial contractility. Okay? In other words, how well this heart is able to pump. Okay? Boom. it does its job, and it's based on preload and afterload. What is preload?
How much blood's in the
Venous
ventricle
return.
before contraction?
Okay, it's how much blood is in the ventricle before contraction. Think about preload as the stretch. Okay, and think of afterload as the squeeze. Okay, so preload is the blood coming into the ventricle and stretching that ventricle. Okay, it's preloaded, it's ready to go. Preload is the stretch. Okay, afterload is the squeeze. All right, that's what's going out, and everything beyond it will affect the afterload. Everything coming into it affects the preload. Okay, does that help? Because sometimes those terms can be kind of a little bit confusing. So cardiac output equals heart rate times stroke volume. Okay, and as we look at these equations, okay, to come up with these things, I don't want you to get too caught up in the numbers, because first of all, what's the only number in cardiac output? What's the only number you're going to know? Heart rate. Okay, so is there a way that you can slap on a monitor and it measures your stroke volume? Not really. Your blood pressure kind of gives you an idea of what your stroke volume is. But again, basically it's trying to get you adjusted to the concept here, okay, of what's going on. So cardiac output, if you've got a heart rate of 160, I want you to think about the ability of that heart to produce a good stroke volume. Okay, is that heart going to fill up with blood? No, it's not. So you're not going to have the cardiac output if you've got a rapid heart rate. Okay, so blood pressure. Okay, here's your blood pressure. Cardiac output times your systemic vascular resistance. Okay, that's basically how you come up with your blood pressure. And what is a systemic vascular resistance? What are we talking about here?
It's like the narrowing of the vessels.
It's the vessels. Yeah. Are they big or are they small? What is your systemic vascular resistance? And what are some of the things that can affect systemic vascular resistance?
Size, occlusions.
Right. Do we have an occlusion? Do we have like a disconnect between the brain and the vessels caused from an injury to the spinal cord? That's the brain is unable to tell the vessels how big or how small to be. Thus, you end up with a neurogenic type shock. Okay, so all of these things are also in there. And then you have your mean arterial pressure. Do you know what? Your mean arterial pressure is one of the most important numbers as you're measuring vital signs. And a lot of times, a lot of people don't even look at that number. Oh, I have a blood pressure of, this over this. I'm good. Okay? In the ICU, I can tell you we gauge mean arterial pressure more than we look at the actual blood pressure. Okay? Your mean arterial pressure is your blood pressure. That is what your body is basing its whole perfusion level on, is your mean arterial pressure. Do your monitors give you a mean arterial pressure? Do you even notice? I mean, that's how unimportant a lot of people look at mean arterial pressures. Most monitors will. It's that funny little number. It's that 140 over 78, and then it's that little number at the bottom that you just kind of glance at and you really don't pay attention to. That is your mean arterial pressure. And do you know what? That mean arterial pressure needs to be at a pretty good level in order to maintain a constant perfusion to the organs. That is your actual blood pressure, is your mean arterial pressure. I can tell you in the ICU, I mean, like, we could have what looks like a pretty crappy blood pressure that you would think, but if our mean arterial pressure is at least 60, do you know what? We're good. And sometimes as we're dialing in our vasopressors, we've got them on Levophed, and we've got them on, all sorts of other vasopressors, dopamine or whatever. We will dial it to the mean arterial pressure more than we will the actual blood pressure. Okay? We really want to pay attention, yes.
So So can you help explain a little better what mean arterial pressure looks like? I mean, I can read the formula, but really what are we looking for quantitatively, and then also what does it
60
mean?
to 80 is really the area. I mean, 60 is low. Okay, 60 is kind of low, but that's like the minimum amount of pressure that your kidneys need to perfuse. Okay, so 60 is kind of the minimum. 60 to 80 is kind of where your mean arterial pressure needs to lie, or where it triggers. If you start getting close to 60, this is where your body starts kicking in some other backup mechanisms to try to drive that mean arterial pressure up a little bit. Okay, so, but yeah, so as you look at this, you know, what I want you to get from this is I want you to pay attention to that number a little bit more. When you look at when you take your little machines out and you put on your automatic cuff, and you know, back when I was in EMS, we didn't have automatic cuffs. We did everything manually, and so we would have to sit and calculate that out in our head to figure out what our mean arterial pressure was. Now, the machines, automatic machines, will tell you your mean arterial pressure. But this is how the machine comes up with that mean arterial pressure. It's your diastolic pressure plus 1/3 pulse pressure, which is your systolic pressure minus your diastolic. So your pulse pressure is the distance between your systolic pressure and your diastolic pressure. So if you take your systolic pressure minus your diastolic pressure, that's your pulse pressures. So as we talk about narrowing pulse pressures or widening pulse pressures, that's what we're talking about. And they're significant as we look at different, even down to head injuries, okay? You'll start seeing widening pulse pressures or narrowing pulse pressures in other circumstances. This is what we're talking about, is the pulse pressure, the difference between the systolic and the diastolic.
So if you have somebody that's 120 over 70, then that would be the mean pressure would be what, 83, 86?
Yeah, I'm not that good at math to be able to,
So
but
70
yeah.
would be 70 plus 1/3 of the difference between 120
Of your
and
pulse
70,
pressure.
which is 50, so a third
Yes.
of that is 16. So 16 plus the 70 would then be the 86.
Yeah.
Is that correct?
Mhm.
So that, I mean, we all know that that's a good
That's a good,
pressure.
that's a good mean arterial pressure.
Okay, so if you got somebody that's what, 180 over 100, so then that would be 100 plus a third of the distance, so 80, third of that is what, 26 or so, so that would be 126. That's higher, so what does that tell us?
Do you know what? So when you've got a higher mean arterial pressure, it's not as critical, especially in a shock state, as a low. Okay, so the main goal is to not allow that mean arterial pressure to get too low. And what you'll find out, like in head injury lectures and stuff like that, is a lot of times your blood pressure will actually raise. Like, for example, you know, we used to be really worried about higher blood pressures in a stroke patient, for example, because we were worried about their blood pressure being higher. But what we're finding is that a lot of times the brain will elevate that pressure to maintain cerebral perfusion pressures because of an elevated, you know, perhaps an elevated intracranial pressure. So the body actually sits and tries to compensate. And we're going to talk a lot about the different compensatory mechanisms that the body actually does to try to protect the brain. The brain, the heart, the lungs, the kidneys, they're the most selfish, stingy organs in our body for very good reason, okay? They've got to have that circulation. They've got to have an adequate circulation at all times. In other words, in order to keep going, okay, to keep functioning correctly. And so the main thing that I want you to remember is, you know, in a shock patient, low blood pressure, bad, okay? In any sense of the form, you are like on your way out if you have a low blood pressure in a shock patient. So, and in just about every patient, you want to just maintain adequates to normals, and that's what we're trying to emphasize here. So other things that play into the physiology of perfusion is the autonomic nervous system. Tell me what you know about the autonomic nervous system. And this is where I know a lot of eyes start to glaze over. Okay, it's like, oh crap, all these stuff, I just don't get it. Okay. Tell me what you know about the autonomic nervous system.
What's the fight or flight or rest or relax?
So
Fight or
it's the
flight,
fighter,
something like
yeah,
that.
it's so, when I think about the autonomic nervous system, I think about translate autonomic into automatic. Okay, that's probably one of the easiest ways to remember what the autonomic nervous system is responsible for. If it's automatic, it's probably coming from the autonomic nervous system. Okay, so it controls the cardiovascular system. Do you have to think about making your heart beat? Nope. Okay, happens automatically, right? It's regulated from the upper part of the medulla oblongata of the brain. So it's the medulla, okay, that is responsible for the autonomic nervous system. That's kind of where it all originates from. So when you hear about someone herniating their brain stem, okay, the medulla is right there. Okay, that's when things related to the autonomic or the automatic nervous system start to fail. Okay, that's where you start to see the bradycardias and stuff like that as that person is dying. So it's regulated from the upper part of the medulla oblongata. It's what controls and is part of the sympathetic nervous system, and that's where that comes in the fight or flight. Okay, so the sympathetic nervous system prepares the body for physical activity during a stressful situation. Okay, it's basically the turbocharge. All right, something's happening. Something's wrong here. Boom. Let's open this all up, and the sympathetic nervous system is what is the fight or flight. Okay, get you ready for that. Okay, now obviously, if you've got one nervous system who does all of that, you need to have another certain nervous system to bring it all back into homeostasis. And which nervous system is that? Parasympathetic nervous system. Okay, that's the rest and digest. Okay, so you have the fight or flight, and you have the rest and the digest. Okay, and so the parasympathetic is kind of the governor on the diesel engine, okay, or whatever, that helps just kind of bring it all back. It's like, okay, fight's over, okay, time to calm down, let's rein it in, and then the parasympathetic system kicks in and starts to bring everything back. Okay, it's the mom going, it's okay, it's all right, let's get this back together. So it's the rest and I call it the rest and digest, okay, system. So here are two charts, and I think this is in your book as well. So tell me, as you look at these signs and symptoms, which one is the sympathetic and which one is the parasympathetic? So as we look at this thing, the pupils dilate, okay? Arteries constrict, lungs, bronchial relaxation, in other words, they open up, okay, the bronchi expand. You have an increased heart rate, increased force of contraction, and increased conduction speed. So which one is that? Sympathetic. That's your fight or flight. So why are each one of these things happening? Pupils dilation. Why do your pupils dilate?
More light in.
Yeah.
Be more
Take it in.
surroundings.
Exactly. Take it all in. So I can see exactly what's going on. Okay, so I'm taking it all in. Arteries constrict. What does that do? Elevate your blood pressure, okay, right? It brings your blood pressure up, okay? The bronchioles open up. Why does that occur?
More oxygen.
More oxygen crossing the membrane, and more CO2 being able to be blown off, right? The byproducts of, like, if you're running, not only does your muscles need more oxygen, but what are they doing? They're producing more waste, right? Which needs to be gotten rid of. And so it opens it up just so that from both sides you can get a better conduction, okay? Better diffusion across those membranes. The GI tract slows down. Do you see a benefit there?
Whole blood, the rest of the body.
Yeah. Let's just expend the energy where we need it. I don't need to be doing this digestion right now. I need to be using that energy elsewhere. Okay, heart rate increases, okay, to keep up with the demand of the fight or flight. Increased force of contraction. Okay, I've got a greater